This week in Pediatric Oncology, the podcast exploring hot topics and exciting advances in childhood cancer. TWiPO is produced by Solving Kids Cancer, nonprofits located in New York and London dedicated to improving research and supporting families, because every kid deserves to grow up. Subscribe to TWiPO through your favorite podcast platform.
This week in Pediatric Oncology, the podcast about new advances for childhood cancer. Hi, everybody. Welcome to episode 102, recorded on Tuesday, August 23rd, 2022. I'm your host, Tim Cripe from Nationwide Children's Hospital in Columbus, Ohio, affiliated with the Ohio State University, now trademarked. And I'm here along with my co-host, Brenda Weigel. Welcome, Brenda.
Hello, Tim, and hi, everyone.
And we have a repeat guest with us today who probably needs no introduction for the vast majority, if not all, of our audience. Doug Hawkins. Welcome, Doug.
Happy to be here. I guess I don't know where I was in between 1 and 102, but somewhere before.
Yeah, I know you were at 80. I think you might have been on one before that too. And that was 2 years ago, that one most recently. And we talked about the vision for COG. I think you had been relatively newly minted as the chair of the Children's Oncology Group at that time, after having served as the disease committee chair for soft tissue sarcomas and lots of other million of roles. In preparing to introduce you today, I made the mistake of printing your CV. So all 46 pages spit out of my printer. But it's very impressive. I'll just summarize briefly for the audience. You received your BS in chemistry from the College of William and Mary in Williamsburg, Virginia. Then you graduated from Harvard Medical School, and you were awarded the New England Pediatric Society Prize for the Outstanding Graduate in Pediatrics. And then you gave up the East Coast, moved to Seattle, and have been there ever since, getting your training in pediatrics and pediatric hematology oncology there at the University of Washington, affiliated hospitals, and stayed on as a faculty member. And you're now a professor of pediatrics there in the Department of Pediatrics and in the Division of Hematology Oncology, and an investigator at the Fred Hutch Cancer Center. You have, I counted about 235 papers, 2 of them co-authored with me and 9 of them co-authored with Brenda, and 1 pending or submitted with her. So 10 that I could count. And then, so lots of committees, all the usual accolades and honors and committees, and a lot of impact on the field of pediatric oncology. So thank you for all of your great work over the course of your career so far.
Well, thank you so much. I appreciate the introduction.
So today we wanted to pick your brains about the inequities of childhood cancer outcomes. We were provided by the team at Solving Kids Cancer an image from an abstract that was presented at ASCO this year that addressed this issue, that came from you and the Children's Oncology Group, which showed a lower survival amongst those who are in rural areas and those who are in poverty. I think there was 4,417 children that you guys looked at between the years 1992 and 2018, and the survival curves were dramatically different amongst the different groups. And so we really wanted to dig into that a little bit today and talk about those data, talk about what sort of is the root cause, perhaps, and maybe what could be done about it. So could you maybe start by just, if you have more to describe about that study and those data and your findings?
So first of all, this is not my area of expertise, so I'm feeling very much out of my comfort zone. But one thing I've realized as the group chair of COG is I have to think about cancer very broadly, not just about narrow areas in sarcoma or places where I'm more familiar, but instead take a look at what's the impact we're having on the population of children with cancer, not individual clinical trials. And it's become very clear through research done by others that we have disparities in outcome that are not explained by biology. And that if we really want to see improvements in outcome and survival and side effects, we need to address these disparities that are based on social factors, not biologic factors. I think the abstract that you referred to that was presented at ASCO was actually presented by one of our fellows from Seattle Children's Hospital. It was not using COG data, but he had access to Washington State Cancer Registry data. There were over 4,000 children diagnosed with cancer in about a 20-year period of time. And he was able to use these data to look at where people live, dichotomizing children either in urban locations or rural locations. And they used census tract data. So this was much more precise than zip codes or other ways in order to characterize whether it was population dense or rural. And they also were able to characterize the neighborhoods by poverty, again, using census tract data, which is much more precise than zip code data. And what they found was that when they put all the children together, these are all children treated in the state of Washington for cancer, children who either lived in a rural location or lived in a neighborhood defined by high levels of poverty, their survival rate was significantly lower by a 15 or so % difference in outcome, even though they had the same diseases as the children who lived in urban locations or in neighborhoods that weren't characterized by poverty. And so this has nothing to do with biology. This has nothing to do with the types of cancer they have. This all has to do with other factors, social determinants of health that are leading to children who live in those environments having a higher chance of dying from their cancer than children who live in more wealthy neighborhoods or live in an urban environment.
Has the COG looked at this in their database yet?
So we've looked at it in several different settings, not on a population wide level like the state of Washington study, but rather individual disease categories. And I think it's been looked at probably the two most striking examples that have been published, to my knowledge, come from examining children with high-risk neuroblastoma. Kira Bona at Dana-Farber has done this we're using a number of different populations, but they have included children who enrolled on our high-risk neuroblastoma studies and made it all the way through to the immunotherapy phase of treatment. So these are perhaps the best population to look at. These are children who had access to a clinical trial. They received the best treatment we know of, including immunotherapy in the more recent era. And even amongst this best acting group of children, there are differences in event-free survival and overall survival based on factors like household poverty. This was defined by insurance status, public versus private insurance status. Even though they were all treated on clinical trials, even though they had access to the best treatment, the most advanced treatment that we know of, there were differences in both event-free survival and overall survival, just based on whether they had public or private insurance. And you could also look at other populations, looking at neighborhood poverty as defined by zip code, which again is not as precise as census tract data. So that is really quite striking, that a feature just like do you have public or private insurance could lead to differences in outcome. A similar analysis was published by Sharon Castellino using Hodgkin data from a whole generation of low, intermediate, and high-risk Hodgkin studies conducted within the Children's Oncology group. Hodgkin lymphoma, we think of it as being a very curable disease. In fact, when you pooled the analysis, now looking at differences in outcome based on race, institutionally reported race, there was no difference in event-free survival. But when you looked at post-relapse survival amongst the minority of children who have Hodgkin disease and develop a recurrence, there was a striking difference in outcome based on whether a child was white or Hispanic or African American. And again, this has nothing to do with biology and probably has much more to do with access to care. So if you look at the initial data, it looks okay. But if you look at post-relapse survival, what happens after someone has a recurrence, there's a difference in outcome that is not biologically based.
And Doug, if you think about, and I know we have all seen the maps of the US COG sites, and many of our viewers are familiar with the locations of sites. And there are geographical holes if you look at that. And I think these are striking data and really speak to the fact that we need to address things as a group beyond biology and targeted therapies. It becomes an access issue and access to those therapies, but also all the supportive care, et cetera, that comes with that. How do you see the COG's role in addressing some of this and the opportunities that the COG network could provide in not only describing these issues, but in starting to address them. Have you thought about potentials there?
Yeah. So I think that's really the next step is how do we, describing the problem is not enough, addressing them is more important. I think COG is the right network to do this. Yes, the sites of COG are scattered around the United States and other countries also. There are geographically less population dense areas where there's a paucity of COG sites, but we still estimate that somewhere in the range of 80 to 90% of children, particularly those less than 15, are cared for at COG institutions, whether they're part of a study or not. So if anyone is going to be able to address this on a national basis, it's going to be COG institutions. We also have some evidence that there's equity in access to initial frontline studies within COG. If you look at, there's a recent analysis published in PLOS One comparing COG clinical trial enrollments from 2004 to 2015 compared to SEER data and seeing whether there are population disparities. At a very macro level, the population that enrolls on frontline COG studies looks very much like the distribution of that we see in different racial and ethnic groups based on SEER data. And if you look at other studies like the enrollment in Pediatric Match, just published a few months ago, if you look at the patients who enrolled on Pediatric Match, an opportunity to get clinical sequencing and access to phase 1 studies with targeted agents at recurrence, the population enrolled on Pediatric Match looks a lot like the demographics of the SEER based on SEER. So I think in terms of access at least at first diagnosis, and at least in that one particular study at relapse, we're providing reasonable, similar access to children across the country. But what we really lack is that what you kind of alluded to, which is moving past describing the problem and getting at the etiology. You know, when we discover a biologic biomarker, we see a protein that's associated with a poor outcome. We try to understand the mechanism. Why does that protein, that mutated protein, lead to poor outcome in leukemias or brain tumors or sarcomas? And then we develop an intervention that targets that biomarker. And so just describing that poverty or race or location is associated with bad outcome, that's not enough. We need to understand the etiology. And then we can think about targeted interventions that might address the etiology. I think that points out what are some of our limitations. And the limitations of the data within COG is we have fairly crude measures of these biomarkers. We have institutionally reported race, which is not necessarily what a person might report. We have zip codes to try to infer neighborhood poverty. We have public insurance versus private insurance to try to understand household poverty. Those are very imprecise ways of describing the biomarker. And I think we probably, if we really want to understand and then also target interventions, we need to know more about this risk factor. And that could involve asking more detailed questions than we ask right now, like what language do you speak at home? Maybe it's language is a barrier. Maybe if people report food insecurity or report other features that potentially could be addressed with targeted interventions, we could really understand what these relatively crude biomarkers of race, insurance status, neighborhood poverty, we might be able to actually understand the etiology and lead to an intervention, much like we understand what the mutated protein is doing and how we might target that with a specific intervention.
Just going to follow up on that, is you envision changes to sort of some of the COG supported infrastructure or data collection mechanisms to really get at that being implemented so that we're collecting that data across the board as something sort of moving forward, tagged to any sort of centralized process within COG?
So we're doing that right now with selected studies. For instance, our standard risk ALL study has an embedded household material hardship aim that is designed to correlate that with neurocognitive changes, as well as trying to understand burden of care in children who receive blinatumomab. That's the intervention on the standard risk ALL study. We also have embedded household material hardship questionnaires, collect more robust data collection that tries to define the exposure, not with these crude measures, but more precisely by having patients describe their race and ethnicity, having them describe their insurance status, or having them describe what factors they have experienced that may interfere with their ability to get access to care. That's already embedded in our frontline high-risk neuroblastoma study. That's important because that's the study where we saw these great disparities looking at historical data in both EFS and overall survival. I think that's going to get us much more precise descriptors of what is the mechanism of these disparities in outcome in different populations. And if it turns out that it's food insecurity is the one that's, for instance, most associated with inferior outcome, then there are targeted interventions one could consider, perhaps not at the COG level, but certainly at the societal or institutional level, to address this as the main driving force for disparities in outcome, for instance.
You're mentioning food insecurity makes me wonder if there isn't some biology here as well. One of the most eye-opening studies that I read over the last, 5 or 10 years, I think, was when they said, well, response to checkpoint inhibitors depends on your microbiome, and it was shocking to me to think that could influence. So, thinking about food insecurities, I'm wondering if patients in some of these categories might have a little bit different biology or different microbiome or different microenvironment within themselves as a result of either where they live or how they live, or what their challenges are at home, or their stress levels and so forth. So that's probably another layer of complexity that's going to be difficult to get to in terms of accurate data collection about each individual person. What are your thoughts?
Well, you're thinking like a laboratory scientist. You make an observation and then you say, well, what's the cause? There's mutated protein X. Well, that's not really the cause. It's how it interacts with this, through a network of other signaling pathways. And so, if public insurance status is actually a biomarker for food insecurity, which leads to alterations in the microbiome, well, that's testable. If that's what we really need to zero in, we need to do that. But I think right now, if all we collect are institutionally reported race and ethnicity data with no variability, you can't be of mixed race because that's not a possibility in the way we collect the data. If we only collect insurance status, public versus private, we're not going to be able to get at etiology. I think we're going to need to collect more specific information to really understand the etiology of these disparities, and then that will lead to the targeted interventions. And there may be a whole cascade of associated factors, and maybe we will need to look at the microbiome as the final common pathway that leads to this difference in outcome based on insurance status, for instance.
Do you think there is enough in the way of funding support and people with sort of the trained skill set in this type of research? Because getting to sort of what Tim was saying is most of us are really good at sort of the basic or translational science, but this really gets into population science and gets into asking questions in a slightly different way. And are there opportunities to strengthen those resources to really get at what is really needed to delve into the data to actually then really move into intervention?
Well, we need investigators who are not me, people who actually have trained to evaluate these factors, people who understand the science and can design studies the right way. I think we do have leaders in the field. I was also struck by how many of the presentations given at ASCO this last year really focus on inequities of outcome. And so even those people who've devoted their careers trying to study new agents or biology or new ways of doing surgery or radiation, when faced with these enormous disparities of outcome that would dwarf any intervention that we think about in a clinical trial, are really saying, we have to support this sort of research. And so I'm enthusiastic that there are investigators who said, this is what I want to do. I'm pleased to see that there are young investigators who say this is what they want to devote their career to. I think we just need to make sure that we are able to conduct clinical trials, that they're able to get the funding they need to ask these sort of questions and address these issues, because describing the problem is not going to be good enough. If we just describe BCR-ABL and stop there, that wasn't acceptable. We had to go beyond, understand the mechanism, and develop an intervention.
Well, and it also, I think, could have worldwide impact, right? We always say 20% of the pediatric cancer patients are in the U.S. with 80% survival, or in Western countries, and 80% are in undeveloped countries with 20% survival. So whatever we learn here may also be applicable in worldwide. I think that speaks to importance. And so I appreciate your call for young investigators to go into this sort of field and get the right training as they're developing their careers in order to be able to ask these kinds of questions.
Yeah, we did. We were fortunately with some external funding from a philanthropic source, we were able to support a competitive application for young investigators who are interested and want to devote their career to disparities research and within the Children's Oncology Group. And so I think that working with our different committees and particularly people who are interested in these healthcare disparities issues, I think we can support their early career development for people to develop this as a focus for their academic careers.
Doug, if you had to think of sort of some key messages on what we know right now about the state of disparities and inequities, sort of key take-home messages for our audience in the state of our knowledge right now, what do you think those would be?
Yeah. So maybe the first one is a call to arms. This is appalling. I mean, these data are simply appalling, and we can't turn away. We can't say, well, that's too hard. I think that they're just appalling, and they're pervasive. I mean, you can look at multiple different diseases. We see the same problem. I think it's not good enough just to say there are differences. We need to try to get to etiology, and that's going to require us to have much more specific information. But I am optimistic that if we understand the etiology, we can develop interventions. And also, if I, again, take a step back and not thinking about individual clinical trials, but thinking about the population of children with cancer, if we're going to make a difference, we need to address issues that are not just the next clinical trial with an intervention of a new drug or a new way of doing surgery, et cetera. We're going to have to look at these disparities in outcomes, because we could develop the most effective treatment for cancer, but if we can't give it to all kids who could benefit from it, we're not going to see an improvement in outcome on a population basis. So I think we can't turn away. This is appalling. We need to address it.
And I think the opportunities are myriad there to really start digging deep into how we can affect that change. And I want to turn it now to Tim for any additional comments or questions as we move to close.
I think just the one thing you said that really strikes me is that the differences can often exceed the differences of a new drug or a new combination or a new strategy. And so we're not just talking about subtleties here, and as you said. And so this is really, really important. And that to me has been a little bit eye-opening for this conversation, because oftentimes we don't think that these disparities are that different or that impactful. And the study that even people on trial, on the clinical trials, enrolled in the trials, who are getting the best of the best, that this is affecting. So really, I just want to reemphasize that point you made. And this is an area I think that's certainly been way understudied and ignored too long, and now coming to light. And so appreciate you're here discussing it. That's all.
Well, thank you so much for inviting me. I think this is a really, as I said, this is not an area in which I had spent my career. None of the papers that I wrote, either with you or with Brenda, involved disparities of outcome. But I think this is one of the most pressing issues for us to address as a community of pediatric oncologists and within the Children's Oncology Group.
Mm-hmm. Yeah, and I just want to thank you, Doug, for really raising this issue, and also the importance of the Children's Oncology Group and its ability to address it. I think we have to start addressing these issues to move forward in treating all children with cancer. And so I really have appreciated your insights and really highlighting this major issue that I have to admit, I was struck by the enormity of the disparities. It's impressive, and it's concerning, and it's a call to arms. So thank you. And all looks like that's it for this week. And I really thank Dr. Doug Hawkins again for his leadership and for joining us today to address this important topic of disparities in pediatric cancer. I also thanks to the team at Solving Kids Cancer, a nonprofit charity dedicated to improving survival through creating novel treatment options for children. Remember, the more we learn, communicate, share ideas, and work together, the faster we'll reach the day when all childhood cancer is preventable or curable. As always, keep up the fight, and thanks for listening to This Week in Pediatric Oncology.
We welcome your comments, questions, or thoughts on topics for future episodes. Just drop us a note at TWiPO@solvingkidscancer.org. You can follow Dr. Cripe on Twitter at KidsOncDoc, send an email to Dr. Weigel at weige007@umn.edu, and find all TWiPO episodes at solvingkidscancer.org.